Yeah, they use it. Yeah. It's like a East Coast fountain school, but they don't subscribe.
And we have lots of folks from LA. Or is it close to San Francisco?
Oh, yeah.
It's maybe like 2 hours, hour and a half from San Francisco.
It's like 80 miles.
Yeah. And traffic, yeah.
So we would fly out sometimes to Oakland
Yeah.
or SFO, and it's an extra Sacramento. Ticket prices might do it.
Yeah.
Okay, co-chairs, I show 12:59. We're just about 1 o'clock. So whenever you're ready.
Excellent. Thank you, Terry. Hello, everybody. Thank you for attending today's subcommittee, the MLAC Subcommittee on Access to Care. My name is Kim Schlessinger. I am co-chair of the committee along with Emily Rivas. Do we need to do quick introductions or are we okay just to dive on in?
We have WCD staff in the room and SAFE is here and they'll be doing a presentation a little later. So small group in the room today.
Okay. All righty. Well, we'll go ahead. The agenda has been posted on the website and we have added some structure around the time limits. So we will try to stick with that. There will be a little flexibility with that, but we'll try to keep on schedule. So the first item is the review the scope statement and objectives. And I don't know, Terry, are you able to share that?
Do you have that? Just a second. We're checking and seeing if we can put that up. Do you have that? You don't? Okay.
Is it on the website?
Is it on? It is on the website. If you want to take a quick look at it, just a second. It is on the May. Let's see.
Go back to May meetings.
No, it should be right there. Subcommittee scope statement. There you go. Okay. Here we go.
1 second. Sure.
Okay. So co-chairs, I don't know if you want to share a little bit, but we had a pre-meeting and we talked about this being a living document, something that we're going to continue to look at each meeting and make sure that we're staying within the statement and objectives. And if things need to change as we're moving, don't let me put words in your mouth, co-chairs. So we want to make sure that we come back to this at every meeting and that we're moving in line, or if we need to change, that we make changes as we're moving through each meeting. So did I paraphrase that correctly, co-chairs?
Yes, you did, Terry. Yes, that was spot on. Thank you. And there wasn't a lot of edits to the original draft, but I think we did. There were a couple, so hopefully those were made. So if we can take a quick look. Yeah, I think we got that in there. They wanted to add the in there, I think from my notes, the self-insured third-party administrators into the scope statement.
You know what? That might be in the second draft. This is the original draft. So you're absolutely
right. Oh, that's
right.
the original. Okay. All righty.
It's in the second draft, and I will make sure that that is updated on after this meeting and is on the June 4th meeting. So I will take care of that.
Okay, so we'll put that on the next meeting just to review draft number 2 with the suggested edits, and if anybody else, I was just gonna say, if anybody else has any other edits, to please submit them to Emily and me. That'd be great.
And me also, I can take care of it as well. I also had MCOs and TPAs in there as well, so.
Okay.
Okay. Got it. Thank you.
Mhm. Thank you. All right, well, moving on to the next item, we have Ann Klein, President of Majoris Health Systems, and Ann is going to delve in a little bit deeper on the white paper that she has shared with the subcommittee on the MCO's perspective on access to care in the state of Oregon. So Ann, thank you for joining us today and for giving us more insight to this very comprehensive report that that you have provided. So I'm going to go ahead and just turn the tables to you and let you go.
All right, thank you. And I'm just going to go ahead and share my screen. I did put together a couple slides just to, Terry, if I'm allowed to do that.
Okay, can you do it now, Ann?
Let's see.
You know, we had some problems before, so we gotta be careful sharing screens.
I know it. I know it. I promise this is all PG.
Okay. All right. The majority paper is on our website too. So there you go.
Yes, perfect. First, thank you, co-chairs of the subcommittee, for inviting Majoris to be a part of this conversation. It's an important one, and we're happy to have opportunity to engage. As Kim already introduced me, I'm Ann Klein, president at Majoris Health Systems, which is one of the managed care organizations for workers' compensation in Oregon. And here to talk a little bit more about the white paper, mostly with just the goal of trying to pull out some of the tangible points and insights that we think are kind of key to what the data sets there are. The original inspiration really for providing a report like this back in April of last year is that while the topic of access to care for workers is not a new one, and which makes sense because really that's one of the core purposes of the workers' compensation system and managed care organizations is facilitation of care to injured workers and making sure that they are getting the appropriate and necessary and timely care. What we have seen, though, is an increase in the number of inquiries that we were receiving and the discussions and concern surrounding the topic following the pandemic. And for Majoris, usually when we start talking about solutions, what do we need to do? We always find that the best place to start is to take a step back and say, what do we know? And we respect that we only have our perspective to provide, but the hope was that by providing sort of a comprehensive overview of what we do know, at least a beginning start of it, that it would begin to build out that framework where as we get together and discuss what can we do, and just as importantly, what needs to be done, what's working and what isn't working, that we can do that on a framework of shared realities, understanding of realities and facts. So this is hopefully the beginning, and here we are with a subcommittee on the very topic. And so for us, it feels like a great direction to really get that engagement. Jumping into it, kind of the key piece for us when we start talking about this topic is to understand how we fit within the broader framework. And a key piece is that Oregon is facing a medical provider shortage, regardless of payer. And that does mean we need to update our presumption that has always been there a little bit, that if a worker is having difficulty in accessing care and scheduling timely appointments, that it's because they're an injured worker and that it's because they are covered by workers' compensation. And over the years, that reality has shifted. And what it really starts with first is there are not enough providers to go around to all the various patient populations, depending on their geographical service area and specialty in particular. And the question now starts first with provider capacity. Are there providers available to consider scheduling? And then shortly thereafter, it absolutely does not leave the story, is also the question of provider willingness to treat workers' compensation. And importantly, this challenge that Oregon is facing of provider care shortages is not unique to us. It is a national story, and it's forecasted to increase in the next 10 years. And for us, what we think is a key takeaway there is understanding that it's going to require both short-term and long-term solutions. And in the short term, efficiency is going to be the story, because if there aren't really providers elsewhere to recruit from, and instead it's more about investing in growth of overall providers and individuals pursuing medical professions, it takes a while to grow a provider. It's usually quite a bit of training that goes into that. And so in the short term, what we need to be looking at is how do we ensure that we're being as efficient as possible. And when I talk about efficiency, there's two sides to the coin. The first is that we want to support providers and give them the resources they need in their clinics to be efficient in their operations. We don't want to gum them down. The other side of the efficiency coin is we want to be efficient in how we consume those available resources and ensure that we're being respectful of which providers should we be sending where, or which workers to where. An example I'll give you to illustrate that concept is going to reference back to an article that is cited in our white paper. And that article is focused on the discussion about the shortage of neurology, which has been around actually for quite some time, just nationally. And part of it is discussing how do they increase the number of neurologists that exist to address this shortage capacity issue. The other subset of questions was more focused on how do we ensure that those getting referred to neurology truly need neurology. Because what they were finding or are finding is that the neurologists are being asked both to provide their neurological care, but also to see patients to determine, do they need neurological care? And so there's this question where if you could shift that over to general and family practitioners, where they have just a little bit more training in neurological care and expertise for them to feel confident and competent in making that determination. Do you need neurological intervention? That could then increase the neurologist's capacity to provide neurological care because they're focused on those that truly need it. And so I think those types of questions and ways of framing solutions is important and shifts it beyond just thinking about provider count. And then the other component that I think is pretty apparent as we look at the data is the shortages and the drivers behind those shortages are nuanced. It really is not just a one question of do we have an access to care challenge or barriers? It's that within access to care, there are multiple different nuances and layers. It varies depending on the area of the state, the licensure specialty, and the individual patient care needs. And because of that, I think as we talk, what do we see in terms of barriers and solutions is first really tightly defining the barriers and making sure that we understand which each of those components are, and then talk about solutions that are tailored to each of those components. And then the last piece that I think is also important as we look at this data and we recognize and respect that there are barriers and that there are forecasted shortages that need to be addressed and considered, we also have a really strong workers' compensation system. We continue to be one of the highest performing in the nation, and many workers are accessing the care they need and when they need it. So we have opportunity for improvement. We always do. We also have a history of success and tools that can help us navigate through this next set of realities and healthcare landscape. Next, I'm just going to try to do some subsets of the data. So it's not everything that's covered there, but some of the key points and add a little color. First is really just a visualization of what I just covered in that we have a challenge in terms of sufficient medical providers for the estimated patient demand within Oregon, just in general. The Oregon Office of Rural Health, in their methodology for estimating available provider resources, primary care specifically, to estimated patient demand landed at a nearly exact balance of 0.98, which also really indicates there's not a lot of resiliency there. And the other piece is, as of course, those providers may be on average an exact balance, but we don't have a equal distribution of providers and patient populations. Another data set that we provided in the paper is looking at a survey of physician wait times conducted by Merritt Hawkins, which found that the average wait times nationally for an individual to get an appointment with primary care was 22 days. In the Portland metro area in 22, it averaged 45.6. But then again, peeling back those layers, that there is nuance comparatively for claims enrolled into the Majoris MCO, which is the data set we have, looking at from time of enrollment to first office visit. So that'd be a medical office visit, not all treatment, just a medical office visit. We averaged 22.8 days for the Portland metro area in 22. And then drilling down into that time to care measure of accessibility, what we had looked at is to try to quantify and get an insight into what that looks like across the state. We provided that average of enrollment to first office visit across each of the GSAs, with just a call out there that if an individual was treating with physical therapy or some other component of care, that's not counted. We're just looking at the first office visit. And second to that, enrollment is not, in fact, mostly is not at time of injury. And so it's not that they went from, they're going without any care on this piece. This is more of just once they got enrolled, when was the next office visit? And what we looked at, looking for some potential correlations and ways to ascertain what supports or drives that average wait time, we looked at also the ratio of enrolled claims to our network provider physicians, specifically within that same GSA, with the thought that if you have fewer workers to network providers, that should increase accessibility because there's more to go around. But the data did not demonstrate that. Instead, if you look, you can see there's not a direct correlation in having a lower ratio of enrolled claims to Majoris Core physicians. What is interesting and insightful, since that correlation didn't help and numbers weren't quite the magic tool, is looking in some of those areas where, based on the ratio of enrolled patients to Majoris Core physicians for the GSA, for example, GSA 4, which is the Portland metro area, or GSA 7, which is the Eugene area, those actually have lower average wait times. And what they also share in common is that they have more occupational medicine focused providers. And so then that changes that thought of a provider not being one-to-one, where in GSA 1, which is the North Coast, that one provider is much more likely to be treating multiple different patient populations. So our enrolled workers are sharing that resource with other patient populations. But in GSA 4, many of injured workers can go and treat with occupational medicine providers, where that's the only patient population they're sharing that with is other injured workers. So that one provider increases the capacity for workers' compensation, which we thought was a key takeaway there. Then I do have an addendum. This is not in the white paper, but we have been working on some updated statistics based on various inquiries we've gotten subsequent to publishing the paper. And we will be publishing that addendum as soon as all the stats are done. This one, a stakeholder requested looking at that average wait time instead as median days. They posited that there might be some outliers that were skewing the average up, and that played out in truth. So if we're looking at here 2024 data, the median enrollment to first office day is about half of what we were looking at when we were looking at averages, which also shows just the slippery nature of data and lesson learned for myself of being careful which question you ask to ensure that it's giving you the information that you're looking for. Oops. We also did a subset of data. One of the common questions that we were fielding is this question of what did COVID do? And one way for us to try and answer that question and provide some quantification of it was to look specifically at surgical procedures and how often was a surgical procedure that was approved, how often did we have to do an extension on that approval beyond 60 days? So generally when the MCO issues an approval for a surgical procedure, they're given a 60-day window to get that procedure scheduled. You can see 2020, the frequency in which we needed to extend that beyond the 60 days spiked, which makes sense since there were, I believe, 2 moratoriums on elective surgeries. What is also really important to see is the fact that while it has improved, it has not returned to the pre-pandemic time. We're still sitting relatively elevated from that. And a couple key pieces that stand out to us. One, delays in care, particularly things like surgical intervention, are likely going to increase the overall demand for care because it's going to generally take more physical therapy. We've got higher risk of deconditioning, recovery may be elongated as well. So when we're seeing this delay, it's not just that they had to wait for the surgery, it also is likely compounding the overall effect by increasing the overall cost of care for that individual and the overall utilization of provider resources. And then the other piece of insight from this is when we're talking delays to surgeries, there's multiple reasons why a surgery might not be scheduled. In this case, it's not that there are not surgeons available. The surgeons were ready and could have scheduled earlier. The challenge is that the surgical slots were not available. So either there was backlog with the hospital or ASC with other surgeries that were attempted to be scheduled, or quite commonly, very key trend was it was the anesthesiologists and that there weren't enough anesthesiologist resources to couple with the surgery. And we've also seen a shift in other utilization patterns. There's an increase in demand for pulmonology, cardiology, neurology. Those are all now being utilized more because of COVID and long COVID. And we also have seen a trend inside and outside the workers' compensation system on behavioral health demand and just seeing more utilization of that resource. And then another subset of data that we looked at in the paper is very much an MCO perspective, which is asking the question of how much care is being delivered in network versus non-network. So the system is set up that if there are insufficient network resources, the worker can pursue non-network care if there's an appropriate alternative available. And so looking at how frequently do we see non-network care can give an estimation on sufficiency of network resources. The one call out there is we never really expect that we would get to 100% of in-network care because we also do have subsets within the work comp framework that allow an individual to treat with their established primary care physician if they want to and the primary care is also willing to follow them, even if they're non-network. But it is still a good estimation of that network sufficiency concept. And in 2022, on average, 77.1% of care was provided to the care that was provided to enrolled workers was via network options. And then 2024 data that we now have available, that was a little bit higher. So 79.6% of care provided was in network. And then I have another addendum as we've continued to work on our statistics. So this subset of data or insight is new because it was not available at the time that we published the paper in April of last year. We just started tracking it. So recently, well, I'll take a step back. Always there has been a requirement for MCOs that if a worker requests it, they must provide a list of 3 providers willing to schedule that specific individual, or the individual can pursue care outside if they're not given those 3 options. In 2024, the rule was updated to establish a 14-day deadline on providing that list, or the worker could automatically pursue non-network care. And so we began tracking those instances to gain a little insight into the questions of the MCO's ability to provide that list of 3 willing providers in that time frame, the impact on accessibility to care when the worker was allowed to treat outside the network. So by allowing them to then, after that 14 days, seek non-network care, did that allow them to see a provider quicker? And then also looking for some insights into the reasons that prompt a worker to request a list of 3 options. And a couple of things to note, because the list must be providers who have confirmed they will schedule with that specific patient, most of the providers require a records review before they do that. And that one builds in just an additional step and effort that's required. Some providers just aren't interested in going through that process, particularly because the patient's not even a guaranteed patient if they say yes, since there's an option of 3. But even if they are willing to do the records review, it still is that timeline piece. So when we look at Majoris's inability to provide the list, that could either be that we received responses from providers who declined, and so we weren't able to get that full 3, or we just weren't able to solicit an answer of yes or no within that 14 days. So there's both of those scenarios. And then when we drill into the statistics themselves, with these requests for 3 providers within 14 days, 45% of the time, a list was not provided in that time frame. We were unable. 41% of the time we were, so about evenly split that we were capable of doing that. And then 14% of the time, the process was discontinued because the worker resolved the issue a different way. They found a provider they wanted to schedule, or in some cases, they settled their claim. And then when we drill in and we look at, of those where the list was not provided and non-network care was allowed, 34% of those did not pursue any additional care. That could either be that when they initially requested, the claim was closed, and when we didn't provide the list, the claim stayed closed, or they chose to settle. Those would be the 2 most common scenarios that I saw within the not pursuing care at all. 39% remained in network, either with their original provider or with a new one, and then 27% did go outside the network for their care. And then when we are looking at, so when do we get these requests? What we found is that the majority of time, it's 6 months or more after enrollment, which to us indicates that it's not really that the individual is unable to establish with care, but more that there's something that is changing the need of care. Either they're looking to change their provider, or maybe there's a referral to a different specialty, but there's something going on in the care that is prompting this, rather than at enrollment, I need to find my first provider. And then drilling in a little bit more, on average, the number of days to treat from the request was 33.6 days when the request was provided, and then 49.3 days when the list was not provided, which does seem to indicate that the allowing of non-network care didn't improve timeliness to care, and may in fact have worsened it slightly. And then we also saw 25% of the requests were when the worker had no provider or needed to establish with a non-network provider. For example, they got enrolled, they had been treating with non-network, and so now they're looking for a network alternative. That really correlates with the fact that the majority of the time the request is coming pretty far out from initial enrollment, that it's not so much finding a provider, but more there's a change in what we're looking for. 13% of these came after a provider had made their attending physician at time of request had made a determination that they were medically stationary. And 7% of cases also included some barriers that came from worker behavior choices like harassment of medical staff or frequently canceling or no-showing, which reduced the willingness of providers to schedule, or a discharge of the patient because of that. There's a lot more of the details and data that we could discuss, but I think I've already used up a good chunk of my time. For us, where we wanted to land is that is one perspective that we have. We know that there are other perspectives, and we think it's very important that we try to get a well-rounded understanding of the barriers as well as the successes and the recognition of what is working just as much as the identification of what isn't, within the context of understanding the accessibility challenges are mirrored in the general population. And so the considerations of what we can do need to factor in the fact that we're not alone, and that we're sharing resources. And it also presents potentially opportunity for new partners outside of the work comp system that are trying to solve the same problem. And it's this multifaceted set of considerations and barriers. So we expect that the solutions will also likely be varied and not a silver bullet. And as we mentioned at the beginning, for us, we think that it's twofold. Short-term planning focused on efficiency and leveraging the existing resources and technology, and long-term planning on how do we help Oregon build its provider resource base, both from individual licensed providers, also all the resources that we need to support those providers. They require administrative support care. If they don't have a scheduler, you're going to see a delay in care. If they don't have a biller, they're going to have a hard time maintaining their efficiencies within that. So also broadening that understanding of what do we need to invest in to support the overall healthcare system. And with all of that, we do want to just reemphasize that we also are proud of the Oregon workers' compensation system and believe we have a lot of tools and that there are past successes and existing strengths that can help inform us as we move forward. And that's what I have. And again, I likely went over time because I always seem to. But if there is time for questions, I'm very available, or I can make myself available at any other time as well.
And thank you. That was an excellent presentation. No, I think you're right on time, maybe even a little ahead. So if there is any questions right now, we do have some time to take some questions, answers. Just let me see if there's anybody on the oh, I see. Is it Thais? I hope they said that right.
Hi.
Yes.
Sorry.
Hello.
I'm curious, in looking at all of these data polls, have you done any comparisons and looked at the numbers of non-enrolled injured workers in the state? There is a very large portion who do not utilize an MCO.
Yeah, Majoris doesn't have access to that data, so which is why the paper itself is disclosed MCO perspective, because we don't have access to provide that same data analysis to non-enrolled, because we don't see those details. We don't see those claims.
Yeah, no, I appreciate that. I guess just as a foreshadowing, if we can, as looking through all of these in general, keep in mind those perspectives for non-enrolled workers and what can be done to help simplify the system, I think, for everyone involved, because those non-enrolled workers and providers who are not working within an MCO really need the most support. And that may be one of the biggest barriers that we're looking at as an overall theme going forward.
Yes, certainly respect that the
Yeah.
experience is different, and for us as the MCO, we are essentially there specifically to support the workers and the providers. So we are an additional tool that I'm sure changes the experience and outcomes for workers that aren't enrolled, but also recognizing that there's a really wide range of injured workers and their needs. And not all of them probably would make sense to be enrolled in an MCO as well. So absolutely agree. There's multiple perspectives needed there.
Thank you.
Co-chairs and Thais, I just wanted to let you know, we're just trying to look at all kinds of different data, and we did invite Anne to present her paper and provide that data. And And again, we'll be looking at all kinds of different data as we roll things out. So more to come on that. Okay.
Okay, I don't see any additional hands up. So we'll go ahead and move on to the next part of the agenda, which is workers' comp division update documents. And a presenter is Matt West, our administrator.
Good afternoon. Thanks for having me. Matt West with the Workers' Comp Division. So I have 15 minutes. I doubt I'll use it all. So if Ann wants some of my time, she can have some of it. So just wanted to give an update or provide a couple of documents for the subcommittee. I think you should have these hopefully, but the first one is just a matrix of healthcare providers and their kind of authority and abilities within the workers' compensation system. In the Division 10 rules, there's like 4 pages of rules that list all this. So our policy team, it's the wrong document, Jeff.
Sorry.
That's not there.
That one.
Yeah, we'll get to Candyland in a minute. So this is the matrix. Out of the rules, it's just kind of it gives a quick snapshot of the different types of who can treat, who can be an attending physician, kind of what the limitations are on each provider type. As far as treatment, authorization of time loss, releasing to work, and establishing impairment findings. I know one of the amendments in House Bill 3374 looked at expanding authority for certain types of providers. And so if that's a topic for discussion, this will be a good resource to kind of look and see what the current state of things are within the workers' compensation system in Oregon. So we just wanted to provide that. Happy to answer any questions if there are any. If not, we can go to the very colorful Candyland map. So this is we were asked to share this with the subcommittee. It's a high level life of the claim of an injured worker from injury, through the process of when the insurer makes the decision, and then each of the little touch points that the workers it's really for the workers' compensation division program areas and kind of our touch points within the claims process. And if you get towards the end or it's claim closure, it could go preferred worker program or vocational assistance, and then there's the resources that the division provides. So it's a worker's journey and the touch points within the services the division provides. And that's also available in Spanish if anybody would like.
I was going to say this one's in Spanish. The matrix is not, though, correct?
Yeah, we don't have the matrix in Spanish. Anyway, so again, just 2 documents for the subcommittee and those involved to kind of look at and digest. Happy to answer any questions. And then just a quick update on the data that we had discussed during the initial subcommittee meeting. Terry and I had a good meeting with our SMART research team, and they're already looking at pulling data and showed us some kind of draft charts and things that they found related to. We had talked about looking at using the medical billing data to look at the different kind of number of unique providers that are operating within the workers' compensation space, and hopefully compare that to the total number of providers in Oregon by provider type. And they're looking at breaking that down into kind of metro area versus rural Oregon. So hope to have by the next meeting, I think, is that their goal is to have some data that we can share with the subcommittee on what they were able to come up with. That's all I have.
Thank you very much for that. So for the next meeting, the research team will be able to provide some data that they're looking at now.
That's the goal. Yeah, they think they'll be able to. Yeah, and if not, we'll give you an update and let you know how close they are. But it seems like they should be able to by whenever the next one is.
Yeah, I think they're going to give you a summary to present.
Oh, I'll be presenting.
Landed on. Yeah.
Yes, I will be presenting a summary.
Okay, thank you. So the next item on the agenda is a presentation from SAFE. We have Ivo Trummer, Elaine Schooler, and Brian Null. And I will go ahead and hand over the forum to the three of you.
Thank you, Madam Co-Chair, and co-chairs for the record, Ivo Trummer, Government Relations Director for SAFE, and I'm just gonna wait till the presentation comes up. I want to frame this up and then basically turning over to Brian Null. I will say we were asked to present on the data that we presented here in last November. So as we were first in front of the committee, kind of talking about the legislative concept that we then came forward with during the session. The data you'll be looking at and the data Brian will talk about is basically the exact same slides that we used last time, but for the very last one, the very last data slide where we have some updated numbers. These are 2013 through 2023 numbers, so a 10-year look. 24, we are just getting some preliminary numbers, and we want to come back and present on sort of the most recent set of data that we'll have for the past year, 2024, but we also want to come back when we have confidence that those numbers are accurate and we've done all our work. Before I turn it over, I just want to kind of briefly set the stage. SAFE, we are the state's public, not-for-profit workers' compensation insurance provider. If you take the entire state, the entire market, self-insured, insured, we provide workers' comp insurance for 55%, 56% of the total market. Then you have about 100 self-insured entities, and the rest is covered by 250 private insurers. We started operating in Oregon in 1914, and I always get this mixed up, but I think our first policyholder was a logging company, and our first claim was a roofer who fell off a roof. Construction and logging, you can imagine 1914, very dangerous and very injury prone. It has gotten much better, I will say, but I'm telling the story to say we still can insure those industries: construction, logging, agriculture, manufacturing, trucking. We also insure a lot of the healthcare providers that are not self-insured, and we also insure the vast majority of the public entities in Oregon, the state, the universities, cities, counties, special districts, a lot of them. But for 5 of very large local governments, think of City of Portland, Salem-Kaiser, school districts, et cetera, but we cover everybody else. We work very well with Ian and Majores, as we work very well with all 3 MCOs that are currently operating in Oregon, Majores being one, Providence the other, and then Kaiser as well. 3 is what we have left. Until a year and a half, 2 years ago, we had 4 still, but Caremark ceased operations. If you go back to after Mahoney at the early 1990s, we had actually quite a list of MCOs over the time, but over time that has dwindled. We have 3 left. We work very well with all 3 and have a great partnership. I also want to say we share the pride that Ian expressed in sort of the system of workers' comp in Oregon. It is really a great system, and I think we all stakeholders, the division, everybody should be proud of what we have created. Before I turn it over to Brian, I just want to say this is data we've been looking at, and it sort of shows a couple of trends that have us worried over the long term. It does take longer for injured workers to get treatment. That is not good for the worker. It's also, if we pay indemnity costs, time loss, it gets more expensive for the policyholder. Medical costs are going up, and they're trending up. We're seeing this everywhere. And again, sort of the double whammy, if costs go up, that will be reflected in the policyholder's premiums in future years, which is not good for the policyholder. But lack of access to timely treatment, to quality care, is also not good for the worker. And so our approach during the session, and today we're just talking about the data, but during the session was sort of a proposal to tackle this. And with that, Brian, I'll turn it over to you.
Thank you. Thanks for having me. I'm happy to be here. I'm Brian Null. I'm Industry Insights and Medical Research Manager at SAFE. And my daily job there, I work on the actuary team, though I'm not an actuary. And my role is to do analysis and kind of inform the actuaries about things we might want to be looking at to inform their work. So this work actually grew out of some of that work during the pandemic. We were trying to understand mix of services and things that might be happening during the pandemic and post-pandemic, and whether injured workers were being able to see providers, and whether it was going to change what medical costs might look like for their like future-looking work, which is what they do all the time. So our job is to kind of look at the data inside out and upside down and see what we might see. So this grew out of that, and so I'll describe what we're looking at here a little bit. We looked at physical medicine because that is a major part of medical costs, as we all know, in workers' compensation. And I would say on a calendar year basis, about 40% of injured workers who have time loss payments also have a medical service in physical medicine. So it's an important part of medical work and workers' compensation. I'll just note, we have interpreters on here because we were looking at whether our injured workers, what kind of access they had to interpreter care. So that will not be part of our further discussion in this presentation, but that's why it's on this slide. But you can see on this slide that post-pandemic, there was a distinct decline in each of the primary physical medicine categories. This is a count of unique providers rendering a service for us in each of those service years, 2013 through 2023. And you can see that distinct cutoff. And though a bit of a rebound, not a rebound to pre-pandemic levels. So that was an area of caution for us when we were looking at this data. We're going to switch gears slightly on the next slide. We can go to that one. We also, of course, we're looking at office visits are even more common. About 70% of our injured workers on a calendar year basis of all injured workers, whether they get time loss or not, go to get an office visit from a doctor in one of those low, medium, or high level office visits. So as you can imagine, most injured workers go to see their doctor. A very distinct decline in medical physicians rendering a service for us, unique counts, after the pandemic, mid-pandemic and after. You can see if we add in nurse practitioners, and I had physician assistant in my data. I apologize, that's not the current term, but that's what we still had in our data at that time. But you can see that rebounds it a little bit. On the next slide, you can see when we combine those, that brings the number up close, but still not quite there in terms of the unique count. So when we combine all of those provider types for office visits, it does rebound that number a bit, but we're still behind in terms of unique count from pre-pandemic. So on our next slide, we're going to get back to this is the slide that gives us the most caution. This is the annual change in days to first physical medicine service from our receipt of a claim to the earliest physical medicine service by geographic service area. So we'll see in a bit that yes, in rural areas it is longer, but you can see that statewide, the change in days to first physical medicine service has increased annually at a significant percent. Overall at 6.2% every year. But you can see every single geographic service area in Oregon has seen a significant increase every year over these 10 years that we were measuring here. So that was where our area of concern came when we thought, oh, it is getting harder and harder to get in for that first visit, or it's taking more time. And I think we can go on to the next slide, which will show this is that aggregate. You can see in 2013, we were down closer to 10 days. And by 2023, we were over 20 in median days to that first visit, which, as Ann pointed out, sort of gets rid of those outliers that can skew the number one way or the other. But so we were taking that median. But in our minds, that's a significant jump if you're talking nearly doubling those days over that time period. And then I think we can go on to that. This is that slide by geographic service area. We don't show all of them, but we show the ones that had what we would deem statistically significant numbers of injured workers. Of course, all injured workers are significant, but there were low enough counts that it kind of skewed the data a bit. But you can see that though the rural areas have higher counts, it's significantly increasing statewide, even in the more populous regions. So it just very much stands out when you look at it year by year. And then finally, this is the flip side of everything. You would think with perhaps the decrease in access to care that costs might be going down, but in fact, the opposite is true. Costs continue to rise. And this graphic is this shows you disabling claims with a time lost payment, but this is just the medical costs. And this is the 12-month % change in medical costs, updated as recently as Q1 2025. So this is our most recent data on a quarterly basis. 12-month rolling % change. And you can see that is 8.2% is well above any inflationary measure that we'd be looking at. And this would be comparable to what the Bureau of Labor Statistics produces every month for their inflation rate. This is the average cost per claim. So it would be similar to that consumer price index number in terms of a corollary. And you can see that only real dip was at the height of the pandemic and limited access to medical services. And we've been seeing significant increases in that 12-month measure since that time, to a point now that is very cautionary. So even with these limited access.
May I ask a question?
Yes,
Sorry,
absolutely.
I should have asked before. So when you talk about the inflationary rate, if I don't even know how to say this, if it were normal inflationary rate, would that be different if we were just talking about the lack of providers? Did I say that? Did that make sense?
You mean on this inflationary rate?
Yeah.
Or
Yeah, if inflation wasn't
this is not taking, this is only our cost increase for medical costs.
okay.
So we're not adding anything into it. This is just the pure, how much is our medical costs increase year over year for safe medical costs for our claims.
Okay.
So yeah, so we're not adding anything into it like the inflation rate or anything like that.
Okay.
This
all
is
right.
just how much our costs have changed for on average per claim year over year. So it's a pretty pure number.
Okay.
I saw a hand up from, I think it was from Bennett's. Are they still there? Nope. Brian, I had a couple questions just for clarification so I understand. When you say physical medicine services, so you're talking about any sort of service that's not like behavioral health or mental health. Is that correct?
Would be physical therapy, chiropractic, licensed massage therapist, acupuncture. Those are what we categorize under physical medicine.
Okay.
So those sorts of treatments.
Okay. Oh, I see Bennett's back.
I'm sorry very much. I've been here. I've been trying to unmute my thing for like 2 minutes and I finally succeeded. That's my fault. Actually, I kind of lowered it before because I think the question was answered. Thank you. My question was just when you say there was an 8.2% rise in medical costs in April to April 24-25, you're just talking about your total medical costs. That's not an increase in like the same medical service, correct?
Right. That is average cost per claim.
Average cost per claim. Thank you. That's average. I think you had said that to the last person, so that's when I lowered my hand. But I just want I had trouble raising and lowering the hand and then unmuting. But the average cost per claim, thank you very much. Thank you.
Clarifying, yeah, thank you.
Okay, and then Brian, just a follow-up to then my other question. You said 40% of injured workers, they require the physical medicine services. Did I hear that right?
Yeah, I would say that 40%, we have payments in physical medicine for 40% of our injured workers who have a medical payment have one in physical medicine.
Okay.
So it's a very common service.
Yeah.
Second to just office visits in terms of commonality.
I didn't catch that. Say that again.
Second to office visits in terms of commonality for a service for our injured workers.
Okay. Thank you. Thank you for that clarification. Were there any other question, comments?
I had a quick question, if that's all right. Have you done any comparison, like, so we have the number of providers operating in workers' comp is down. Have we compared that to the number of claims? So, like
The number of claims
total
coming
claim
in?
counts, yeah.
That's a great question. We're working on that now. Frequency is down some,
Right.
but not to the degree that costs are up and provider counts are
Yeah,
down.
I didn't think so. I was just curious
Yeah.
as we hear claims or frequencies lowered. So
Yeah.
So,
Yeah, that's a great question. Yeah.
Thanks.
Hey. All righty. So we are, I think, is it anything else with this questions, comments for this agenda item before we move on? No? Okay, well, one, thank you for presenting that. That was, again, very helpful data for us to chew on here. The next item is, I think, provider feedback. So Terry, I don't know if we have any providers yet for this meeting, but do you want to just kind of give the committee just what the overall, our goal is for that?
Yes, I actually received a list from some of the managers here, and I've reached out to several different people, and I believe we'll have a provider that will come to the June 20th meeting and present information about treating injured workers and their perspective, some of the barriers that they have, and so more to come on that, and they will be at the June 20th meeting. So, and we have different providers that will be coming to all the meetings. We're going to hold that space open. And so we'll have doctors, we'll have nurse practitioners, we'll have physical therapists, we'll have everybody on that matrix that Mac showed us. So I'm trying to get everybody that we can, and non-traditional providers, naturopaths, everybody that we can think of. So, I'm reaching out to as many as possible, and people are emailing me back because they want to participate. So great news.
That is.
So yes, so that space is going to be reserved, and we won't have people participating then.
Excellent, thank you. So we're heading into the final agenda item on public comment or stakeholder feedback. And I think, Terry, did you have anybody reach out to you to speak today?
Yes, I believe that Dr. Sabo is online, and he wanted to provide a few minutes of public comment.
Okay, thank you. Dr. Sabo.
Yes, Dr. Vern Sabo, representing the Oregon Chiropractic Association. Relative to access, I would like to take the subcommittee back to a survey that was conducted some time ago. It's a Blue Survey Group for Safe Corporation, prompted by the division. It's this document here. And to reinforce, some 5,000 surveys went out to the medical professionals, which included medical physicians, osteopathic physicians, nurse practitioners, physicians assistants. Of the 5,000, there were 77 respondents, 1.5%. Of the survey also went out to 1,500 chiropractic physicians. 445 chiropractic physicians responded, or about 30%. And so therein lies part of the problem, is a lack of wanting to participate. And so you have a class of healthcare providers, arguably one of the best trained, if not the single best trained, in musculoskeletal injuries, not the least of which is back injuries, which is the #1 work-related injury, according to this document by DCBS. In fact, 53.8% of all claims are sprain strain type of injuries. And of course, we treat more than just backs. We treat shoulders, elbows, wrists and hands, hips, knees, foot and ankle. And then Ivo referred to, and also Mr. Brian Knoll, the rising costs. And so last week, I also serve on the federal legislative committee of the American Chiropractic Association. A colleague in Missouri alerted me to a Workers' Compensation Research Institute study of 2021. And it was a study of some 2 million claims from 28 different states. There was a 61% lower cost when injured workers were treated exclusively by chiropractic physicians. The average was $1,366 versus $3,500 when they were not involved. And so, and then fewer drugs, fewer special imaging, MRIs, and so forth. So I wanted to point those things out. You're looking for providers. You have a whole class of healthcare providers that's our forte. Thank you.
Thank you, Dr. Sabo. I'm just for clarification on the provider matrix, chiropractors were listed there. I think right under the medical providers. So so there is access to chiropractors. Chiropractors are allowed to see injured workers. So is there, in this access to care, is there something specific more that you would like chiropractors to be doing or seeing, or?
Well, yeah, first of all, there's the issue of attending physician for the life of the claim. Part and parcel to that is when it comes time for when that person is at maximum medical improvement, doing a closing exam and documenting any findings of impairment. We're limited to 18 visits or 60 days, and within the MCOs we're also limited. So we're not around to do a closing exam. And so a great majority of those closing exams are provided by the IME vendors. There's an inherent issue with that. The other issue is injured workers. I treat a lot of Oregon Health Plan patients. So many of them are injured on the job and they're told they must go to the local occupational medical clinic, never being told they can see the healthcare provider of their choice. And my poster child in that situation was a retired U.S. Army nurse, a Samaritan nurse, worked for ER over in Corvallis Hospital, who was struck in a crosswalk and was never told she could come back to me. I had treated her. Portland VA had sent her to me. So there's that issue. There needs to be clarification that they can see the healthcare provider of their choice. And so what we want to see for our injured workers, for our patients, is attending physician for the life of the claim so we can treat and advocate for them. For the great majority, the 18 visits in 60 days is plenty. They're not the issue. It's the small minority that end up with impairment, usually ligament and or disc involvement.
Thank you for that additional information. It looks like we have a hand up from Thais.
Sorry, it's me again. I just wanted to respond to some of the concerns that Dr. Sabo brought up about the change in physicians and not being able to do a closing exam, et cetera. From the perspective of the processor and an examiner in their everyday life at a desk, the way that the rules are written right now and have been for quite a while, only an attending physician at the time of being found medically stationary can either provide that closing information or concur with an IME that has been done. So it's not that IME doctors are just willy-nilly saying, oh, you saw a chiropractor and now we're saying you're done. Those injured workers have either found a new attending physician within that matrix that you were looking at earlier, and that physician has then done the closing exam and provided the findings, or there has been an independent exam done because they are unable to, or for whatever other reason, and that attending physician has again come back and reviewed the report and agreed with those findings. And just of note, Sedgwick's perspective on the nurse practitioner and physician associate status, we find it would be helpful, I think, if they were allowed to act as an attending physician within those timeframes that they're allowed, without those other exceptions. And I have a feeling in other conversations that have happened that those groups would agree. But while we're on the topic.
Yes. Thank you for that additional perspective. It's appreciated. Okay. So Terry, there's no other stakeholder feedback or public comments? Okay. All right. Well, I think then we are at the end of our agenda. We are a little bit ahead of time. Is there any other additional thoughts or comments, questions?
Co-chairs, I did just want to let people know that there is meeting summaries. They're not formal. We don't vote on them. I send them to the co-chairs. If they're good with them, I just put them up on the meeting minutes on the for the meetings. Sorry, that's a lot of meeting minutes in there. So if the co-chairs approve them, then they go up on the meeting minute website. There, let me say that. So those will be available as soon as they approve them.
Yeah. Yes. Thank you, Terry. And thank you for providing all these documents and attachments, and every agenda is on that website. It's very organized and easy to find.
I'll say thank you, but somebody else does that for me.
All right. Well, our next meeting is Friday, June 20th from 9 to 11. And I think all our future meetings will be on Fridays. This one was a little off scheduled. So appreciate everyone being able to join today. Okay, so we have some action items for the next meeting. We're going to look at the scope statement and objectives, the draft number 2. I think we're also going to maybe hopefully see some research from the Stellar research team, and some provider feedback we will have ready to go at the next meeting. Was there anything else? Did I miss anything? Looking at my co-chair, shaking her head. No.
No, I don't think so. I think we're very much in a information gathering stage, right? Like this is it's not nebulous, but it can be a little overwhelming. And so just being able to talk through some of this data is starting to, I don't know, bring to the surface some questions and maybe some paths forward. So it's a lot of intake right now, it feels like to me. So in a good way.
Yeah, absolutely. As our speakers had pointed out, it is, you know, it is a little, a lot, you know, it's a big topic. So it's very helpful to, yeah, kind of have this opportunity to go through all of the different issues and barriers. So. Well, if that's it, I think we'll go ahead and adjourn for this meeting. And I just want to again thank all of the presenters and everyone joining in today.
Thank you, everyone.
Special.